Hi, welcome to the Wounds of the Heart. Here we are once again to help you heal anything that have been caused by trauma, by abuse, by any emotional instability. And this is the platform where we bring guests who are professionals to help educate, to help lead, and to help guide anything that you are going through that will need a mental health practitioner to deal with it. Today I'm here with a beautiful lady, and when the time is up, I will have the chance to introduce this beautiful lady on set. And I'm privileged, and I'm always privileged for me to have you who always sit behind your TV, on your phone, in your offices, just to watch Wounds of the Heart. You know, this program is one of the programs that we deal strictly with mental issues. And right here, if you want to join the program as usual, it's Hope Channel Facebook, Hope Channel YouTube page. We are live there. You can send your comment or anything that you think that you need, and I will respond to it. Or if you want to also join us via WhatsApp, it's 0559 680066, 0559 680066. And as I said, Facebook, YouTube, all the social media handles, Hope Channel GH, you can watch us live there. And if you really want us to also push this program to the senior high schools that I've been telling you, the number to call is 0559 535554, 0559 535554. And we'll be very glad to also have you on board so that we can take this program to the students in our campuses to help them, because they are those that they need this program the most. So if your word is in school, learn, put down something so that when he or she comes, you'll be able to help the person out of what he is going through. So today my guest is a mother of 4 children. She has been doing this thing for the past 8 years and counting. She is a clinical and health psychologist, a member of Ghana Palliative Care. She focuses so much on women's mental health. Today, join me to welcome in the house, Masha Boy Bashiru. Masha, good afternoon. Welcome to Wounds of the Heart.
Hello, Daniel, and thank you so much. It's such a pleasure to be here, and hello to all your viewers and listeners as well.
Viewers, Masha had greeted us. Thank you so much for always being part of this program. Masha, palliative care.
Right.
Ghana Palliative Care. What do you do?
There are a lot of misconceptions of what palliative care means. So I'm very happy that we have this platform to talk about it, because we've had series of events launching from last year, spanning all through this year, to be able to educate the mass what's really palliative care is. So I'm going to talk about palliative care, but I'm going to talk about it from psychological point of view, because palliative care is a holistic approach and it's a multidisciplinary intervention team. So I'm going to speak mostly on the psychological part, but I'm also going to throw some light on what other members of the team also do. So palliative care in Ghana does not really mean is the end of life. Okay, so palliative care simply means how you can help someone right from the time the person has been diagnosed all the way to the end of life. And in some cases, even up to the point of the funeral. Okay? Yeah, so sometimes we go all the way. We hold the person's hand right from the diagnosis, through the treatments, through the interventions, all the way till the end, and also offer support to the families, because families are very crucial support when it comes to palliative care, because they are usually the caregivers. They're the ones who spend a lot of the time with the patients. They know the dynamics of where they're coming from, cultural beliefs, social beliefs. So family and caregivers are very important parts of the palliative care. So palliative care does not look or shun upon family members when we rather encourage them to be part of this treatment. And yes, they get involved at almost every stage of palliative care in Ghana.
Okay. All right. So with this brief summary, what actually is palliative care?
So palliative care simply means looking at biopsychosocial well-being of someone. So you look at the biology of the person, you look at the psychological aspect and the social aspect of it. And then now we are also adding the spiritual aspect of it, because in Africa we can't take spirituality out of it. So every single thing we do has the foundation or basis in some sort of faith or religion. So palliative care simply means holding the patient's hands right from the diagnosis, as I mentioned, looking at ways to be able to break the news, be able to help the patients, the family to understand what the condition is. So we don't only look at cancers, okay? So a lot of people think, exactly. So a lot of people think once it's palliative care means you are going to die of cancer. Yes, we sometimes have pain management as part of the treatment. So this is, of course, is the medical aspect I'm highlighting a little bit. So you are looking at biological, some conditions are progressive in nature. So you want to start right from the beginning and work with them throughout the end. Sometimes there are lots of fears. So this is the psychological aspect of it here. Sometimes just hearing that you have certain conditions, sorry, you might think that I'm going to die. But there's hope. Okay, so our duty as palliative care team members to be able to reassure our patients of giving them the facts of what really the problem is, being able to help them with the interventions that are available, and also find out what's really bothering them. So palliative care is patient-centered approach. So we are moving away from all the creative aspect, and then we are looking at patient-centered. What does the patient need at every stage of their needs? So at whatever needs they come to you, you try to meet those needs at a point in time, and then you move on based on the plan. So it's a multidisciplinary. So we have doctors, we have nurses, we have specialists who are part of palliative care in Ghana. We also have social workers. We now have faith, spiritual workers. So in Kolibu, we do have a priest who is part of the palliative care. I'm not very sure in terms of the Muslim community, yes, but if there is, why not? We also have psychologists who are part of the palliative care team. So you can see the number of professionals that come together to be able to give some support to the patient and also the family. So we do a lot of work also with the families because they are the caregivers. So we want to help them elevate some of the burnout they had and see how best we can also support them in this difficult moment.
So palliative care is not for those who are dying alone? No,
not at all. We have some clients who have neurological conditions and they will need some support. So there's a lots of independency. So they have to rely on someone for some point, either in their maintenance, health, and things like this, in day-to-day functions. So activities of daily life, that's what occupational therapists would have called it. So they will need feeding, they will need care for their tubes, they need somebody to tend them on the bed so that there are no bed wounds and so.
So all these ones are part of palliative care?
Absolutely, they are. But a lot of us think that palliative care is hospice. So hospice usually is end of life.
Those are the medicine out there. That's why.
Yes, so palliative care is like a big umbrella, and there are different things that happen in the palliative care. So hospice care that usually we think is palliative care is what is under the umbrella of palliative care. So usually hospice care is end of life. So there you're just trying to give comfort and have provide dignity to the one who is affected by the condition.
So if it's not for those who are dying alone, which people would need palliative care? What sort of probably diagnosis, which sort of sickness that may need palliative care?
So I want us to think of palliative care as needs-based. I mentioned that it's patient-based. So you have to look at the individual needs. But most of the cases would come as progressive conditions. So a condition that has a tendency to progress over time and then may lead to an end stage. So these are things that usually we'll be looking at. So sometimes you may see people who are having kidney problems, a lot of cancer problems. Some people have degenerative heart diseases. Some have neurological diseases. So usually in my field like this, I usually see people with ovarian cancers, reproductive cancer. So these are usually the kind of cancers I would see in my practice. So these are usually kind of per se, but it does not always mean that it's going to be an end stage. The problem with palliative care is that it is a relatively new field. So people are now getting to understand that palliative care is very important in the medical care. So what happens is that the time the referral comes to palliative care. It's usually towards the end stage. Yes, so that is how a lot of people tend to associate palliative care towards the end of life. But palliative care starts right from the diagnosis. Some people have never heard of what cancer is. So when they are being diagnosed, even with the early stage of cancer, the next thing that there's a lot of anxiety. Am I going to die? Am I going to make it? I've heard all the people who come to specific facility, then they are all going to die. So that alone could be something that I will be looking at as a psychologist, the kind of fear of death people have. So palliative care wants to give you the dignity, will give you respect. We're all going to die at a point in time.
Exactly.
Yes, so we want to give you all the comfort you need, all the information that will be helpful to process and not to make death sound very scary. We want to make it as easy as possible for individuals who come into the palliative care.
As easy as possible.
Yes.
In case you just joined us, we are discussing palliative care, those who qualify to experience this care, and what the work the caregivers do for a patient or a client who is undergoing any severe or any severe medical conditions. And Marsha just told us that it is not just cancer alone. We hear that cancer, those are the things that they need palliative care, but then it goes beyond cancer. And one thing I also deduce from this intro is that it's not always the end of life. At the point in time, there is hope. So the work of palliative care givers, it's huge, and I think that if you are watching and you have a friend, a family member, whoever is experiencing trauma because he or she has been diagnosed with a certain diseases, please let these people reach out to the unit palliative care, and they would help the person. As I said, if the referral comes, it's basically at the end of time, that later stage of life, and that's where they will try to do what they can do. But then if it could have come earlier, so please, if you are watching and you have these things around you, please don't sit there and don't sit there. Please, let's resort to this. And as I said, 0559 680066. You can WhatsApp your conditions or whatever, and please, I'll get to know, and we can refer that cases to Marsha and the rest of the people who are into palliative care in this part of our country, so that at least a sort of help will be given and hope will be given to the person. And as I said, you can also join via our Facebook Hope Channel GH and YouTube same. And you can send your comment there. You can also share for someone somewhere to also want to learn and discuss what we are also going through now. Now, Marsha.
Yeah, I think just not to distract your thoughts. Something just came up as we're talking. When we say that people come to the palliative care very late, what also comes to mind is the caregivers, how worried they are, because when they are coming to when they are nearing their end of life, there are certain medical procedures that will not be very beneficial to the people. So when they come in and see their relatives not being eaten, they are very dull, and caregivers begin to be worried that the healthcare workers are not doing their job.
Oh, it's true. Okay.
So also one of the parts we also do as part of palliative care is to be able to educate the family that there are certain things when it comes to end of life, it does not become beneficial. So a lot of bodily system begin to shut down. So as you see a living person who needs water, who needs food, when people are nearing end of life, those things are no longer important to them. So we are looking at the best practices that will help to sustain the person throughout in the last days. So this is also something that came up because this is a worry to a lot of family members. They feel that the doctors are not doing anything, so I just want to take my person home and then resort to other other facility or other herbal or other things. Sometimes people only rely only on the spiritual. So spiritual aspect is good, and as I mentioned, in our care we are not taking spirituality out, but then you need to be able to add on also the professional voice to whatever you are doing. So this is also something that came up when you were talking about
Marsha, I always say that in as much I'm a pastor, I believe in spirituality.
Absolutely.
The Bible says we wrestle not against flesh and blood. So definitely there are other spirits fighting us. Notwithstanding, if I'm sick of malaria, I go to the pharmacist to get the dose so that I come in, and I add prayer to it. So that stance of me going there to fetch medication means that in as much as we can't take away spirituality also,
Yes.
we are going medically to be fine.
Absolutely,
So viewers,
that's it.
you can't do it alone. It's a holistic approach.
Yes,
Every aspect of it forms part of
important.
exactly. So please, don't wait till it escalates before you go to the hospital and seek care. Once you begin to feel, or when you are diagnosed quickly, don't sit down. Probably there's hope at the end of the tunnel. So I know that it is good to be part of this program, to learn something so that it can keep us. Marsha, do we have types of palliative care?
Yes, we do. So I mentioned, I highlighted a little bit. So that's the medical aspect of this. So you look at the physical symptoms, you look at the progression of disease, you look at how to manage pain. There are certain procedures that need to be done. Example, draining of the fluids, and also everything is focused to be able to help transition as easily as possible, as comfortable as possible. So yes, this is the physical aspect of the palliative care. So all the nursing things that go on into taking care of the patients is also part of the palliative care. So we do fixing of the tubes for feeding, for drainage, whatever IV fluids you need, medication, feeding, adjustment to diet. So everything forms part of the palliative care. And then this is where my part also comes in as the psychological aspect of the palliative care. So you look at the well-being of someone. So mentally, how are they doing? What are their fears at that particular moment? So sometimes someone's fear of the condition can make their anxiety so high, and then they retrogress in their progression. They sometimes don't want to comply with certain medical procedures. They don't want to take certain medications because of the fear. So you want to come in and step in earlier to know where you can balance that, where you can intervene, where you look at the anxiety. Some people have clinical depression during their diagnosis, and this also inhibits the kind of treatment they are going to receive. So they don't want to adhere to the medication. Some of people don't want to even stay in the hospital, but that is the most appropriate thing for them at that particular time. Some people fear certain medical procedures because they know that once they get there, then that is the end of their life. So all this kind of conditions or factors are what we fall under psychological aspects of palliative care. We also have the social aspect of the palliative care. So you look at the family, you look at the caregivers, and I think I mentioned that families are also part of the palliative care. So we also see families. Sometimes we have to break bad news to them. Some of the family members don't want you to break the news to their family because they said, once you tell my mother, she's going to die. So please don't tell her. So when it happens like this, we also need to find a way to be able to be as truthful as possible by also weighing the options. Would this news be acceptable? So you have to prepare the patient. So that's also part of the job we do. Yes, so emotional, you do anything that surrounds emotions to be able to prepare people towards bad diagnosis, towards certain procedures. Sometimes people have been responding to treatment very well, and there will come a time where they are no longer responding to treatment, and maybe certain procedures have to be withdrawn from them. So maybe they have to be moved from the oxygen, maybe they have to move from certain IV fluids, certain medications. Maybe you can no longer swallow medication, so they now have to pass it intravenously for you. So this kind of decision making, you also have to assess how cognitively your patient is doing. Is our patient able to make decisions? Is the patient making the best of decisions? Is our patient having a good insight and judgment about even their own condition? Some people, I had a patient like this who was an elderly woman, and she had a cervical cancer, end stage. And she refused medication. She said the medication will make her more sick and the radiotherapy will kill her and all that. But then she was already at the end stage. So the procedures that were given to her at particular moments was just to relieve her of the symptoms, to make it easier on her body and on herself. But she felt that whatever she was going to go through would rather kill her. And then she refused to take her medication. She was not eating. So physically she was doing quite well, but the disease has progressed and then it has metastasized to other parts of the body. So, this is where you would wonder, how can you help the person? So medically alone was not enough. So you obviously have to bring someone who understands the balancing of this. And that's what palliative care team does. So we sit down together as a team, we deliberate what is the best way to be able to help this person. So you look at the needs. This person is not understanding what is happening. So you assess the judgment, you assess the insight of the condition, also the kind of medication. Can we adjust some medication? Can it be maybe less orally swallowed, and maybe there's an injection, or there has to be something? So this is a bit of medical aspect I'm talking about. And then the family. You also want to know how much information does the family know? Are they reinforcing her fears? Are they assuring her that things are going on well? So this is where you involve the family to also understand what is going on in your family. Your family, do they like medication? Do they like treatment? Do they like hospitals? And sometimes you actually get to know that the families will tell you that our family, nobody has gone to the hospital. We always go to the herbalist, and then he prepares mixtures for us, and everybody gets well. So why is it that only my mother has come to the hospital? So we even want to take her home. So that's why it's important to have a holistic approach with the family as well. And of course, there's a spiritual aspect of it. You have to, we don't downplay any religion. We just have to reinforce the faith basis that our clients have, and then we refer based on the one who has the skills in that particular area. So some people might have more knowledge about what Islam will say. Others may be more prone to understand how Christianity can help someone. Then, as I mentioned, in our team, we have a priest who is also part. So he comes to either help people to pray or help them in guidance or answer some spiritual question that maybe some of us will not be able to do that. So these are usually the basic type of palliative care that we can have in Ghana.
It's viewers. It's that this program brings those who are skilled, those who are professionals, sitting, listening, all these things. These thoughts that she's sharing. It's making me enjoy more what palliative care is.
Right.
And the point that you said, families sometimes they don't want to hear anything bad.
Yes. I've
been to hospitals, places you visit others, and I visited this church member, and in the same ward I saw one woman lie, and I for once know that is the end of though I'm not a palliative care, but what I saw is the end of the woman.
Yes.
Who am I to tell the families who are going hectic, making sure that their mother becomes fit? And I told them I want to offer a prayer. I want to pray for them. And the prayer, God forgive me, man. You see, the Spirit was pushing me to end the woman's life, like how Hezekiah, Isaiah telling Hezekiah, you're going to die, prepare your home.
Yeah.
But the family members can sue me for saying that through the prayers.
Excellent.
So I ended by saying that, but God, your will be done.
Right.
The next time I came to visit the lady, the bed was cleared.
Yeah, absolutely.
And I asked her, so she was sure that at dawn it happened.
Yeah.
So you see, these are when palliative care is necessary. And as you're saying, the team have priests, have psychologists, have all these things that can balance the mental state of whoever is closer to that. People, it is difficult to pronounce or to hear that a loved one is nearing death. It is so difficult. But I think that it is always beautiful when people like her would educate and lead you through the process, so that the one who is seriously sick or has been diagnosed with the sickness will take that person would also be cheerful.
Yes.
As I said, through even funeral, they are still there.
Yeah.
So palliative care is not a joke.
Yeah.
So when they come into the scene, allow them to help the sick and the family members, so that at least you'll be able to enjoy the moment while the person is on.
Yeah.
Masha, I want us to have a scenario.
Yes.
So this person has been diagnosed with a sickness or disease that would take his life.
Right.
Would
Definitely. Okay.
What is the process that palliative caregivers or people like you, how are you going to go through it? I want a practical steps, like what do you do with a client who has been diagnosed, or a client who has walked in to say that this is the report that he has shown you, or she has shown you the report from the health report, and you guys have realized that no. This sickness, for instance, cancer stage 4, that's the stage 4. what do you do with this person? I want
Okay, so I will not highlight a lot on the medical aspect because I
exactly.
don't know.
You're from your point.
Yes, so usually palliative care is integrated very well in some of the hospitals in Accra. Like you can look at it like Teta Kwashi, you have Accra, Greater Accra Regional Hospital, Kolibu, and a few others. I can't think them. So we have quite a number of hospitals in Accra. I think some in Volta region.
Okay.
These ones I know of that have a very good protocol when it comes to palliative care.
Okay.
So it depends on what points the person came in, whether the person was on a general admission, whether the person came in through emergency. But what happens is that at any point, some certain results that come out, and the general practitioner or the specialist may have looked at the results, will feel that this will fall under palliative care, they refer. So as I mentioned, palliative care, we have all the doctors, nurses, and also depending on the ward you have been admitted. So I will speak from my point of view. So when you come to gynecological departments, when the women have been admitted and there's a possibility of them having a faster progression of a condition, and they suspect that this may end not as good as you expect, but then also there are probabilities. So you want to tread cautiously. So the doctors will assess, the nurses will be doing the care, and then we have a whole team. So we have specifically, again, nurses and doctors who are part of the palliative care. So who will do their own assessment? We have those who do the emotional assessment. We have people who are looking at pain assessment. So this will be the physicians and the doctors and the nurses who are doing the physical assessment. You also have, you have to look at the financial aspect of whatever you are doing. So we also have to collaborate with other departments, whether this is going to go to radio oncology department, whether this is going to go to a medical department, whether you have to go to another specialty for. So there's some sort of collaboration between them. So the patient is walked through all the specialties at some point in time. And at every point in time, there's some sort of an assessment going on, objective assessment, not just a subjective view of what is going on. So at whatever points you meet, and then there's a need for us to be able to start preparing the family, we start. Sometimes we don't start directly with the client. So the client may know the diagnosis, but may not know the progression because we are not very sure where the patient is. So we start preparing the family that there's a possibility that when the results come out, based on all the assessment that every specialty have done, we are looking at this may not be looking like a good prognosis of the condition. So we start preparing the family about this. We look at their needs. What do you think will be important for your care receiver at that particular moment? If it's spiritual, we have it. If it's emotional, some people are very emotional and maybe naturally have an anxiety. So you know that when you're going to break news to such a person, there's a possibility that things like this will happen. So you're already kind of aware how the person is before you actually break the news. Sometimes we have conferences, so we do counseling with everybody on board, including the clients. We all sit down, everybody has a specialty to highlight on. So we break the news, we explain, we draw diagrams. So we have that very close relationship. Yes, so we explain, we ask them, we show them videos. We sometimes call survivors of others. So to encourage, to empower. So it's really very different from every other patient. But ideally what happens, there's a flow of treatments, who and what has to do. And at the end of it, when based on the symptoms, based on the progression of how things happen, and if we can anticipate that the person may not have a lot of days to live, we start preparing them to what to do, what to expect, and then we start making them to start looking for plans towards maybe the kind of burial they expect, where they want to do it, which people they want to be in the last days, and whether there's maybe a particular dress the person would like to wear. So palliative care, we don't restrict people, especially end of life, we don't restrict them. So if you have patients who has diabetes in the end stage, we don't say that we don't give them sugar. Sometimes we like to satisfy their last craving because we know that whatever they are going to do, even if it's harmful, it's not going to affect them at that stage because it's already, the disease has progressed and has affected all other things. So sometimes we have people who have HIV/AIDS who has progressed. So you see, it's not only cancer. So they have, yes. So you have to look at how best can we preserve the dignity and to make the person as comfortable as possible. So this is basically the flow of how it goes. So everybody's involved at some point in time. Yeah.
Everybody's involved at some point in time. This is Marsha, a palliative care member of Ghana Palliative Care, and she's a clinical health and psychologist. She's also focusing her Jumani on women's health, mental health, and she's a mother too, so you could understand how passionately she is talking about palliative care. And viewers, in case you just joined, this is Wounds of the Heart, a program where we come with you to help you heal every kind of thing that has caused wounds in your heart. I will be right back. I don't want you to go anywhere. Please stay with me. I'll be right back. Hi, welcome back from the break. Thank you so much for staying with me. And in case you are joining us, we are talking about palliative care and how it affects not only the patient but the families as well. And the process we go through with a client who had been diagnosed with time-bound death, sickness, or something of that sort, and realize that it's not just cancer. A lot of things goes on to bring on board palliative care people. And today I'm here with Marsha, who has been with me since the start of the program, and she is a clinical and health psychologist, and she's also a member of Ghana Palliative Care, and they are doing a lot of things, and I hope and pray that I don't know when we're going to celebrate palliative care in Ghana here, but then
it's in October.
It's in October.
Yes.
Then probably in October we'll bring Marsha back here so that we'll celebrate Palliative Care Day with her right here on the studio to tell us more, if possible, bringing people who are survivors to also encourage others who think that life has ended in their life. So thank you for being a good guest and also a viewer for this program. Without you, this program would never last. And thank you so much. May God bless you. Marsha, what triggers or causes people to get into the stage where they need palliative care?
I think the most one that you might be thinking of, it's maybe some sort of pain or degeneration of a condition. So there's a shift in the well-being of how the person was and how they are. So once that has set in, you might be thinking of palliative care, because there are certain medications that need to be adjusted. There has to be certain routine and certain medical interventions that have to change. So yes, there's just shifts in that. I'll think this should be the basis of how someone may be thinking of palliative care. Also, some may be doing quite very well, but suddenly they decline. They don't respond to any treatment any longer. So yes, this is also one of them. Another thing is better care. So with the general nursing, there are certain aspects that might be lacking, or the general practice that we might be doing. That's why I'm saying palliative care is holistic and multidisciplinary. Exactly. So you're going to have a better appreciation of the clients who comes to you and the kind of help you want to offer to the person. So when you suspect that a client might be lacking in some sort of care that they may be receiving at other places, palliative care might also be one. If you might also be suspecting that the client may be going towards hospice care, yes, palliative care also comes in. But a lot of times you notice that pain is one of them, especially with certain type of cancers. There's a lot of pain that comes in, and managing pain takes a lot of toll on the individual. Yes, so palliative care would be ideal for people like that.
Pain. You made mention of cancer. You made mention of certain stages of cancer pain.
Yes.
A client had been diagnosed with stage whatever of cancer or any other. Let's use cancer, because cancer is the
one that you usually hear.
A lot of people, exactly.
Yes.
But as we have said it, that it's not just cancer.
You have neurological conditions, you have heart conditions, and you have, I think I mentioned HIV.
HIV, AIDS. The AIDS is for HIV. The AIDS is part, yes.
Yes, exactly. The AIDS part, because that's a progression.
Exactly. All these ones needs palliative care. a client comes, he or she has been diagnosed. Everything shows that this person, Asin, will die.
Yeah.
This person still holds on to the Bible, holds on to his religion,
Right.
or the beliefs, and refutes everything that is being told.
Okay.
How do you manage such a client?
So once all medical intervention fail, ideally they'll refer the person to psychologists, because they would want to understand why an individual will refuse something that will benefit he or her. So at that moment, you want to assess the cognitive abilities, you want to assess the insight, the judgment, perceptions, you want to rule out whether there are any hallucinations or delusions at that point. We also do work with psychiatrists at some point in time, because some conditions are on the extreme, at the extreme end. So some people might have extreme depression, and at that moment psychotherapy may not be appreciated, medical interventions may not be appreciated. So you need to have some psychiatry reviews there, where they have to, do the medical intervention from the psychiatry point of view, and then they refer back to the psychologist. So it's a multidisciplinary. So we throw it back to each other until we find the solution to the person. But then yes, the patient also has a free will, and if by all assessments it indicates that the patient is fully aware, present in time, understands the dangers of all this, the person may have the right to refuse care. Yeah, the patient has full right to refuse care, may actually even write against medical advice, discharge against medical advice. But that is where you have gone to the extreme cases. But you have to lay out all the possibilities to the client, and it's up to the client to choose. So it's patient-centered, Daniel. You remember I mentioned. Yes. So you have to look at the needs of the patient. If the patient feels they don't want to do any medical procedures or whatever it is, we can't force the person. But it is our duty to try our best to be able to lay out all the dangers, the pros and cons of what happens. If you go, how much time you have. So these are all things that we discuss in therapy or during counseling. How much time does the client have if they refuse? Is this imminent? Is this something that they can't do? Is this something we can't discharge? Sometimes patients feel they are strong until they go home and they start to see the rapid decline. And sometimes they walk back in themselves and said, I think you were right. Some don't come back, and then you hear the unfortunate news, of course. But that is all at the free will of the patient. We can't force someone to be on admission against their will. No, that is not something we can do.
So if the client, as you said, they have the free will to go or to stay, and so what happened to the family members who bring such people?
They are usually lost, because they have tried their best. But Daniel, another issue is that sometimes family members don't even know what is going on, because the patient says, I don't want this information to be passed on to all the family members, and we have to respect that. So at that moment, the patient refuses treatment, the patient wants to be discharged, the patient doesn't want to do anything, the patient just wants to go home. And the family that is supporting that patient, maybe financially or emotionally, that patient clearly tells you that I don't want any family member to know what's going on. I don't want them to know I'm going to die. I just want to go home and I'm fine. So you have to respect that. But you check in with the person from time to time, because you do have contact details. So you check in, we're just checking in on you and all that. Yes. Sometimes we can do some home visits, but all that fully depends on the patient's consent. We cannot do without patient's consent at any stage of any care, being it palliative or the general care we give. And psychological care is one of them.
So do you guys break confidentiality?
No. Confidentiality is the hallmark of palliative care. So confidentiality can only be broken when there's danger to people or danger to himself.
So now he or she says that she doesn't want to receive any care, she want to go home.
Yeah.
How sure are we that he or she is not going to I don't know whether you get what I'm saying. How sure are we that what the person going home, now they know that they're going to die. They know they're going to die.
Yeah.
So now I don't want to receive any treatment. I want to go home.
Yes.
And the person's, you can't tell the person's people, family members, about why he or she says she want to come home or he want to go home.
Yeah.
I am with a view
Okay.
that there should be some sort of, in counseling, it's just if the person want to destroy something or
Yes.
kill this. But this one, the person knows he will die already.
Right.
But going home, is there no possibility that something may happen? Because once I know I'm going to die, I won't die alone. I may die with people. Because people may have that perception. And we don't have any clause understatement that we can break confidential. Let a family member know that that the ward says their family member says that she doesn't want to receive treatment again and that she's coming home. And we don't see anything like that.
That's why you assess the person's mental health. If you pay your assessment and you know this person is a danger to society or danger to himself, you have the right to report.
Okay.
Yes, but this is, if the person is refusing treatment, unfortunately there's nothing you can do. You can only emphasize, you can elaborate, you can highlight the risk, but you cannot force the person to take treatment. So if pay your assessment with the mental health and you think this is going to be a risk, yes, you have the right as a clinician, as a therapist to report that.
Is it easy for them to accept that they're going to die?
No, it's never easy to accept you're going to die, regardless of the state you are in. That's why we do the preparations. That's why we are fully involved in the process, right from the first day all the way to the end. Some people might have terminal agitation. So that is when the person at the end stage can actually feel they are going to die. So there's some both biological and psychological comfort that you offer. There are certain medication that will help to bring down a bit of anxiety, will help to slow down the rate at which someone is breathing in, just to make the person calm and relaxed. So there are certain medications for that in the palliative care. And the psychological aspect too, you try to provide a conducive environment to have family, immediate family, relatives, whoever they wish to be part of that process. Sometimes some of the family members may not be conscious at the time you suspect they may be entering the life stage. So you can see that they may be having the death rattles. So you see those sounds that usually people make when they are getting towards the end stage. So yes, it's scary, it's unpredictable, but hearing is usually the last sense to die. So we will assume that the person can still hear. There's still some activity going on. There's a brain activity still going on. They are still breathing by themselves. They are still able to move some parts of their body, just they are not very conscious. So you try to have family members around, depending on what they like to do. Maybe some people like to read, so they will read it out to the person, maybe a favorite book, a favorite poem. Some people would like to have someone to sing. I had patients who had specific hymns they liked, so their family members who come in and sing by the bedside, even though the person was not responsive. Body touch, so every touch that people do, so you can tap the person, you can rub the person, you can squeeze the hand, maybe do some makeup or do some bodily massage. So yes, the patients will feel it even if they are not conscious. Yes. So all these things help the person to know that at least at some point in my life I was so loved and then I'm ready to go. Also, some patients will not leave until they see certain family members. So they are hanging on to the last thread until they see their loved one and then they finally close their eyes. Some may close their eyes, will still holding on until maybe they hear someone in, or they're actually waiting for that person to leave the room, and then you see that they finally take their last breath and it ends.
You are talking,
Are you getting emotionally about it?
No, not that, but it's like you are narrating a story. It's like and they're hanging on there, and unless they are like life is
It's a very delicate issue, and you understand, like, death is so complex for you to understand how it happens, but a lot of things happen when someone is passing on, and it is our duty to be able to take note of some of those things and relate to them. Sometimes some family members come in and says, oh, my family member can't breathe, because they notice that there's some death rattle happening. The way they are breathing, they're gasping for air. So all these things we have to explain to the family what to expect in the end stages. Sometimes sorry, this may sound a bit, with viewer discretion, someone have their mouth very wide open when they close their eyes. So you have to explain all these things to the family, that sometimes, even when the person's died, there's still a bit of brain activity for up to maybe 4 or 5 minutes going on. So you may see some body spasms, you may see a hand moving, but that person is no longer alive. Yeah. Sometimes you see a tear at the side, you see a bit of like a smile or like because all the air finally comes out from the lungs. So you have to explain all this things to the family so that they don't get scared, they don't have high hopes also, because I've also had patients who were brain dead. So you usually have them artificial breathing with ventilator. You see, but you see as if there's a body movement and all that, but the person has been dead for some hours now. So you have to explain to the family how there's a brain death and you can see some movement, and then we have to explain that we have to, disconnect the person because the person is no longer alive. So these are some of the things we have to do, and this is also some of the job of a psychologist, because you have to prepare them mentally before you begin to break bad news to the family.
Viewers, life is something else. Life is something else. We are discussing palliative care and what makes palliative care so eminent in our society. It is difficult for someone to accept the fact that he or she will die, though every indication means that the person will die. But yet, as much as saying, it is difficult for the person to die. Now, the person who will die is not accepting that he or she will die. What psychological effect that has on the person and the family as well? The person, no matter what, even if psychologically he or she is not fine, she has near death. Yeah. But what of the family, the relative, those around? How do you deal with them?
It's a lot of education, a lot of listening. So sometimes we have to be very comfortable with silence. You allow the family to express their views. Sometimes people express grief differently. You see some family members on the floor, you see some wanting to jump from the window, some want to tear their clothes, and all that is pain, and we allow them to process pain. So we try to have separate rooms for them, try to have space. We have as much time as we can, so we dedicate a team member to be with them whilst we attend to other duties on the ward. So we see them, so psychologists are also part of it. We try to give them as much time as we can to grieve, to cry it out, to be angry. Sometimes it takes a lot of time, but you want to make sure that the family, by the time they leave their loved one behind, they have some sort of comfort knowing that their family member did not struggle, their family member is in good hands. And then you allow them to take, sometimes they are allowed to see their body all the way to the last place, and then sometimes they have to say goodbye. Sometimes they are present for some of the procedures as their final goodbye, some are not. So it really depends on the condition, the type of ward, the type of relationship you've had with the people around, depending on what kind of family member you are. Yes, of course, very young children will not be allowed in there, but then if it's the final wish of whoever was there, that can be worked on. Yeah, so it has a lot of effect on the family, because no family would want to accept that. And sometimes family members feel some sort of guilt, knowing that maybe if I took them to a different facility, this wouldn't have worked out. If I reached out for this person, if we didn't wait. But all these are just probabilities. We are never sure how things would have gone at any facility. So we also believe that there's some sort of destiny for everyone. And if it happened like this without the negligence and it was a natural process, somehow they'll come to terms with it at some point in time. Yeah, so denial and bargaining is the first stage of grief. So whenever it happens, no, it didn't happen, this could have happened, we should have done this. So it's understandable. And once every member of palliative care will know the stages of grief. So when you see family members behaving in a certain manner, it is not surprising for us. We know sometimes, as I mentioned, we also feel the impact. Sometimes, most of the times we also feel the impact, but we have to be strong for them and then support them in every way we can. And some of them do keep in touch with us even many years. And as I mentioned, some of our members also go with them all the way to the funeral. And sometimes we keep in touch even after that, because bereavement care is also part of the palliative care. Yes, bereavement care to the family is also part of palliative care. So we do that as well.
This does it exist? Or we are just saying it? Like,
it does exist. It exists, but it's because of lack of education. That's why we are trying to intensify our efforts to help people understand that palliative care is not scary. Once you embrace it, it's a journey that will help you understand that life and death, they are both precious at some point in time. Yes, because this is a transition that needs to happen. And we want to make that transition as easy as possible without having so much anxiety, so having so much pain, having so much worry about what is going to happen. Yeah, but it's a point that we'll all have to move through. So it does happen, yes. I can speak for my facility, but I can't speak for others, but it does happen because we are all part of the same fraternity, yes. So it does happen. Once a facility has a palliative care, we all follow the same protocol.
Okay. Have you ever met like palliative care, ensuring care on somebody? Have you ever, what has been the case where you as palliative caregivers had realized that no, this thing shouldn't have happened? This person, how this person probably is young, how old, this particular thing shouldn't have happened. And when it happens like that, how do you caregivers, how do you feel?
Are you talking from the medical perspective or
both? The team, for instance, you spoke
so something
about,
didn't happen, like
for
was
instance,
a medical negligence or just a condition?
No, the person condition. Looking at the person, associating that condition to the person, and let me use this one example.
Yeah.
In my ministry, I need to bury an 11-year-old child.
Yeah.
And looking at this casket, this small coffin, very small at Kulebu, because she's a child, we didn't do any funeral. It was when they took her from the mortuary, they brought her under that shed and behind the Kulebu where the morgue is. Yeah. And their family stood by. I allowed the family to cry.
Yeah.
After that, I told them that we should do the spiritual thing and let's move. I asked a simple question: why 11-year-old girl would experience cancer or something?
Yeah. Pediatric oncology is one of the most heartbreaking specialties, I think. So far, it's not easy to see. There are even way younger children who die out of cancer. And in Ghana, we have a very big gap when it comes to pediatric oncology. You can imagine in the southern belts, usually Kolebu will be the one to handle all the cases. So look at all the southern belts. How many people can Kolebu see at a time? And some people need urgent care. Cancer is very unfair. You know, Daniel. So yes, sometimes you may ask yourself, but also from our training, we do understand that it can happen at any point, at any time. Yes, some people are actually born with some of the things, and then they begin to progress as they go. It's never fair to anybody, regardless of the age and all, but it's more painful when it comes to the younger ones. Yes, it does. We question it, but not in a way that you might be thinking we are questioning, because it's a medical field and you understand how. What we might be wondering is when people actually knew and refused to come early. So, for example, some patients who were struggling with breast cancer, who were diagnosed with breast cancer in the hospital, refused to come for treatment, went somewhere else, all sorts of things. And then by the time they came back, the thing has progressed and it wasn't looking very aesthetically pleasing. And there were a lot of other complications that arose through that. And this could have been easily prevented, you know, if they just reach out to a unit to understand what really breast cancer is. How do I cope with it? Will I survive? Can I become normal after this? Because a lot of questions that people be asking specifically with breast cancer is that, can I live my normal life at this? Yes, you can. There are a lot of survivors. Now, there are some cancers that have higher chance of survival when they are detected than others. So, for example, bone cancers and maybe blood cancers may be more complex to manage, and usually they are not very visibly, physically visible. So people might be going on with symptoms, going on about normal life for a very long time, and until they started having symptoms, and this is already a late stage when it comes to that. And also sometimes the kind of interventions available, resources, personnel training, all these are factors, and that is also beyond anyone at that point. So yes, we do question, but not like the way you might be thinking. Yeah, it happens even with younger children. Yes, very healthy young adults, and then with no risk factors, no smoking, no drinking, very healthy, fit, and then you realize that there are other complications. Yeah.
All right, we are almost nearing our time in this palliative discussion. And culturally, how do you respect a client's culture when it comes to palliative care?
We are all for it. it also depends on what the what's the person's views or norms or values when it comes to palliative care. So we take all that into consideration. As I mentioned, so spirituality and culture, they are a bit interlinked. So all that is taken into consideration. However, we have to look at the best interests of our clients and what can be practiced at that particular moment. So if there are certain practices that cannot be done within the medical field, and you look at that, this has more disadvantage than advantages towards the clients, there's not something. So we all have to discuss. So maybe unless you have specific examples that you
no, but when it comes to culture, you know, people may think that in what they believe, they need to do some certain things at the hospital space or where they sleep. Do you guys allow them?
As long as it does not infringe on others, yes, it's allowed. So maybe somebody has some rituals that they have to only sleep on one side of the bed. I haven't come across anything or maybe that hasn't been referred to me and maybe the medical team managed it, but I haven't had any referral where they felt things were a bit out of place. I think the only case I could remember is maybe where a client felt that if she eats, she's going to feel sick, and she was hearing voices and all that. So yes, that's maybe something that came to my attention, but nothing out of the ordinary that I can say for sure. But that is always considered in whatever care we give.
Your last word for viewers.
Exactly. So palliative care is not something you have to be scared of. Palliative care is your friend. You need to be able to, we have to hold your hand right from your diagnosis all the way until the last moment. So palliative care does not look at only the end of life, but we want to look at every staging point, even reviewing your medication and everything. You have specialists. It's a very heavy loaded team because you have all the specialties involved. Even sometimes physical therapists are also part of palliative care. So you have a full team who is looking out for your best, is looking for your family. You are never alone when it comes to palliative care. And we also want to encourage other institutions to be able to incorporate palliative care into the jobs you do, to be able to lessen some of the burden that some of you as staff have to deal with. And of course, palliative care is there to stay here now. Exactly, yes, because we have seen the impact it has on our families, and it's something that we are going to continue to create awareness about. We are trying to make it part of the national policies. Yes, maybe people who are more into that to be able to say more about it. But on my level, yes, this is how far we have come.
Thank you so much, Masha. As I said, we're going to bring Masha in October. Masha will be coming here once again too, for us to talk about Palliative Care Day, because we need to know more. And my interest will be the fact that we need to instill hope in people who think that it is over. If you are watching and you have a client, you have a friend, a family member, a loved one who is still saying that she has been diagnosed with a certain disease and it's not going to last long, there's always hope for the person. Don't sit there and assume that nothing will happen. If whatever you believe in, if you believe in that thing, it's going to help you work. Viewers, I am so much appreciative for your time that you stay and stick with me on your phones, on your TV set, or before your TV set, or at work using your laptop or whatever, watching this program from wherever you find yourself. As I said, if you have any question, if you want any referral, if you want to meet any professional, 0559 680066. 0559 680066. That is for WhatsApp, channel WhatsApp. And if you want to reach me directly for help, for sponsor, for whatever it is, it's 0559 535554. 0559 535554. You can follow me on all the social media handles using the word Chaplain Abedu Bidiaba, and you can also get to me there, and I will have time to discuss. I've always been your regular host, Masha Boy Bashiru. God bless you for your time. We're going to have Masha again because once she's for feminine, I know Ma, you have a lot of things, and coming Mother's Day, we're going to have a session for that. Let us see what the Lord will do with us. I've been your regular host, and the name is Pastor Dan Abedu Bidiaba. I'm out.